everybody for joining us tonight. You know, it's been about 8 months since we had a program like this, which is dedicated to our patients who have been diagnosed, friends and family who know people who have been diagnosed with breast cancer, and those who may not have breast cancer anywhere in their arena but want to learn and be educated. You know, it has been a series that's been really popular with invited panelists. I'm the program director of breast cancer medicine for New York Oncology, Hematology. And I have to say that this is one of my favorite things to do. And I always get such an enthusiastic response when I pick up the phone and ask a colleague, whether locally or all the way across the country, you know, would they be willing to spend some time on an evening just having a chat? And everyone says yes. And I am thrilled, number one, number two, and number three, to have these three guests with me. Colleen, I want you to wave hello so everyone knows who you are, and most people do know who you are. When Colleen is my nurse practitioner, she basically runs my practice. When patients see her, they say to me, I thought I was going to see Colleen today. She's been a great partner, and tell us a little bit about yourself, Colleen.
Thank you, Maria. Yeah, no, I agree. I think this night is my favorite night. You know, the patients come in and they're so appreciative of these little fireside chats that we can do and educate. And I think it's really important that we can just sit down casually and have these nice chit chats about questions that people may have or are afraid to ask. So yeah, so I've been a nurse practitioner for 21 years. I work with Dr. Theodoulou at NYOH, and I'm super happy to be here. I love you guys.
Heidi, Dr. Heidi Godoy is joining us tonight, who just got back from Colorado. You can see that gorgeous sun first on her face. So she's a happy camper tonight. We're going to be able to abuse her and pick her brain. One of our very, very prominent and seasoned GYN oncologists. Heidi, I'm going to let you say a few words about yourself.
Sure. Hi, my name is Heidi Godoy. I just celebrated my 1-year anniversary with NYOH. Woohoo! I'm very excited to be here. I feel like this is a great outreach program for our patients. And so I always snap up the chance to come and chat with you, Maria. I love it.
Thank you, Heidi. And I'm really honored to have Dr. Sonia Elguero tonight with Boston IVF. You know, this program tonight is really a kind of bounce through of a patient presentation that I discussed with Sonia right before Christmas, and we'll certainly talk about it tonight. And Sonia has become more and more important in our field, especially in our young patients who still want to have families, even though they've been diagnosed with breast cancer, or perhaps they're carrying a gene mutation that puts them at high risk for breast cancer and may have to visit Dr. Godoy for preventive surgery. Sonia, would you say a little bit about yourself and what you do?
Yes, so thank you, Dr. Theodoulou, for inviting me to be part of this beautiful chat tonight. So I've been working here in the Albany community at Boston IVF, the Albany Center, for close to 10 years. And I will say that during that time, what I've loved is this piece of it, the teamwork to really help not only breast cancer survivors, but people in different stages of, their diagnosis of breast cancer, just different realms, people looking to find out about their fertility potential, and then others who have preserved and looking to use their eggs and embryos respectively to achieve pregnancy. So it's very rewarding. And, I'm happy to be here to help and support and educate.
I have to say that over the past 35 years, this whole arena of whether patients who have been diagnosed with breast cancer can move on and have a healthy pregnancy, and will they remain a healthy mother, has been evolving. And I know over 3 decades ago, most of us were terrified when our patient would ask us, I haven't had a child. I'm only 32 years old. I've always dreamed of having a family. I just got married before my diagnosis. Or I had just gotten my mammogram before moving forward with IVF, and they found a spot. We were terrified as medical oncologists, as surgical oncologists, as GYN oncologists. How do we advise these patients? There were small trials around the world, very small number trials, and none of them had shown any increased recurrence rate of breast cancer in those small trials. But again, they were small numbers and they usually had a healthy mother effect. That means that these were young women who were diagnosed with either a precancerous lesion or very early breast cancer, stage 1, who were probably going to do well no matter what. And, we would talk to our patients about some of these issues, but really didn't have any good data. And then over 2 decades ago, and Sonia, you can chime in on this, we started looking at egg harvesting with a drug called an aromatase inhibitor with letrozole, which is an anti-estrogen drug that we use to treat breast cancer in postmenopausal women or young women who are ovarian suppressed. How did that come into being? What did that, I know how it changed things for me. How did it change things for you?
Yeah, I think, as you alluded to, with respect to just thinking about recurrence, women who have HR positive breast cancer, there's always that fear that if we're going to stimulate the ovaries and produce a higher amount of estrogen, are we increasing the recurrence risk? Are we doing harm? So the premise of using the aromatase inhibitor was to really mask that estrogen, to keep the endogenous or the naturally producing estrogen from the ovaries very low as we were stimulating the ovaries. So in a way, I mean, you think about it, it's genius that we're able to grow follicles and harvest eggs while at the same time keep that circulating estrogen low such that we're not potentially increasing, recurrence risk. And obviously this was before, the newer available data from the positive trial that you're going to talk about later. But back then it was very meaningful to be able to take these patients through stimulation in a manner that we felt was safe and not, at risk incurring.
I remember we were part of the original trials at MSKCC way back then. And, when patients were stimulated with estrogens, we would see a peak. And then with the aromatase inhibitors, it was reduced by 2/3. So we were really encouraged to try to get our patients to egg harvesting and try to stimulate those follicles before we started chemotherapy. And that became almost a standard of care. If a young woman came in and she was, had not had a pregnancy yet or wanted to have more children, was there a time element that we could forfeit to the fertility clinic before we started? And that always made me very anxious. And obviously, depending on the stage of the patient's breast cancer, the subtype, and we know breast cancer is not one disease, it's multiple disease, from being indolent and lazy to overly aggressive, how much time would I have to back off? How much time could I give you, Dr. Elguero, to do your thing? So what do we do? What is egg harvesting?
Yeah, thank you. So first of all, we try to really prioritize these patients just because the acuity is high to get the harvest completed, and then obviously, get them back in the hands of yourself, Dr. Theodoulou, yourself, Dr. Godoy, for further treatment of the cancer. But essentially, from the time that they present for consultation and testing to the time when the harvest is complete, we can do that in a little over 2 weeks if we're being very efficient and maintaining good communication with the patient and the respective team. So, I think that that's very positive that it can be done so quickly. I think that sometimes what's challenging is finding the right time for the egg harvest amidst, the oncology appointments and any port placements or secondary opinions. That part is challenging, but we do our best to work around the patient. And obviously get to harvest as timely as possible so that they can recover, and initiate the respective treatment, which usually has been chemo, doing the harvest prior to chemotherapy.
Surgeons now have become really in tune to this. And oftentimes I'll see a patient that's already visited fertility, even before they visit medical oncology, which is always so reassuring. but we're also talking about patients who may be carrying a genetic mutation. And Heidi, I'm going to throw this kind of at you because, we know that not everyone that's carrying a genetic mutation is preordained to develop a cancer, but there are risks. And some of those risks are concerning, especially in a young patient who have many, many years ahead of them. What do you say to a patient who may be carrying a BRCA1 or BRCA2 mutation, who is, in her early 30s, mid 30s, and what are we doing now regarding their ovarian function?
That's a great question, Maria. I think that this is a very personalized decision that patients make. I think you have to really look at the patient's their family tree, because there's a penetrance, the ability of this gene to kind of penetrate in their family tree, in their family history. If you have a very early and numerous patients, people in their family that have ovarian cancer, you're going to want to consider doing a risk-reducing surgery sooner rather than later. Oftentimes with the BRCA1 mutation, we recommend at 35. BRCA2, we can go up to almost 45 risk-reducing surgery. There's a lot of buzz around possibly just doing risk-reducing salpingectomies. So we know—
You brought that up, good.
Yeah, so we know in a general population, they're called opportunistic salpingectomies, where if somebody at the time of their cesarean section, they're done having children, we take out their fallopian tubes. Somebody has an appendectomy, we'll take out their fallopian tubes. Perhaps they have a hysterectomy for benign indications, whether it be fibroids, heavy bleeding, we take out their tubes. We know that there is an incremental decrease in ovarian cancer based on just doing this opportunistic salpingectomy in regular risk people. So now if you can extrapolate, and this is really all theoretical right now because there's not very good data on, because we can't get enough numbers right now on doing opportunistic salpingectomies where we take out the fallopian tubes, and then perhaps later we would do the oophorectomy once you have the benefits of a lot of the estrogen if you do not have a cancer. So in those patients that present that don't have a history of breast cancer, that have a genetic mutation, we're considering this, taking out the fallopian tubes and then delaying times to do an oophorectomy because there are benefits from the estrogen. Your bone health, your peak bone mass does not really start to decline until at least age 35. Hormonally, estrogen is good for your heart, your head, your bones. And so the benefits for that, when we talk to normal risk women, we say leave your ovaries until age 65 because there's so much benefit to having estrogen in your body. Now you want to turn around and say, okay, let's take it out at age 35. We're setting patients up for osteoporosis, heart disease, dementia. There are a whole host of things that you can really set your patients up by taking their ovaries out early. So it's a very personalized decision, and some people need to have their ovaries taken out for their cancer reasons because they can't keep their estradiol levels low enough if they do have a ER/PR positive breast cancer. But in those patients that are BRCA1, BRCA2, or even Lynch syndrome, we talk about removing potentially the fallopian tubes and maybe doing an opportunistic salpingectomy earlier and then going back for the ovaries. And we're kind of waiting for some data to come out on that. But we talk about these studies. There are 200,000 people in the UK trial. It took years and years and years to accumulate this data. So I think it's going to be a while before we have some concrete data to say we can just say, take out your ovaries now, take out your fallopian tubes now, and then go for your ovaries later. So we're working. I think we're trying to be very flexible.
I think what often Colleen and I hear is a young patient who comes in with a breast cancer diagnosis or is identified as carrying a BRCA mutation. Her mother may have passed away, her aunt is diagnosed, her cousin may have advanced disease, and she comes in and she wants everything done. She wants everything done. She wants a double mastectomy done. She wants her ovaries taken out right away. And, there's a sense of alarm, and you try to calm that patient and wait for a time period where they can kind of equalize that fear and make some rational decisions. But, we'll often hear someone who has had prophylactic surgery or has had a salpingectomy. Ovaries are still in place because they've gotten some solid, good advice from their GYN oncologist. And now they're 37, 38 years old. Their ovaries are still there. They don't have their tubes. They met the man of their life, or they met the woman that they want to have a family with. It doesn't matter whether they're heterosexual or homosexual or whatever, but they want to have a child. So Sonia, what do we do with those ovaries that are still there? Is there any function to them? Is that going to help this woman at all?
Well, I think a lot depends on, as you know, the type of chemotherapy regime, the dosing, the duration, their age at the time of chemotherapy administration, and of course, just baseline genetics. And we're able to assess the ovarian reserve very easily. So we measure a couple of hormones in the serum, FSH hormone, which is the follicle stimulating hormone, and AMH, which stands for anti-Müllerian hormone. And both of these hormone tests are very, very useful to help guide us with what is the reproductive potential for that woman, for that patient. And in addition, if there is a window, how do we stimulate them? So the testing is really twofold, helps us understand, are they a candidate for egg or embryo creation, or I should say egg harvest and embryo creation? And again, how would we treat that individual patient? We also look at the ovaries via ultrasound, and we're able to measure the follicles, including the total number. And as you know, follicles are where the eggs are resting. So that really suffices as a good understanding of their reproductive potential as well. So it's a combination of the blood testing and the ultrasound, which helps us understand, can we treat the patient and how are we going to treat the patient in terms of fertility medication dosing.
Dr. Elguero, do you notice that after patients have a bilateral salpingectomy or some sort of risk-reducing surgery, that their ovarian follicle number decreases, that their reserve decreases? There is some data if patients have hysterectomies that it does decrease their ovarian reserve. Are we talking about an earlier menopause? What does that mean when you actually do have a procedure on your ovaries, and then what do your eggs look like after?
Right, and this is regardless of whether a patient was treated with chemotherapy or not, just, in general. And I think that's, I've gotten probably about 24 questions before this program tonight. And one of the participants actually asked this particular issue, what happens to my ovarian reserve if we're mucking about below the waist?
Right.
Do we know?
Yeah, I think it's a very interesting question. I have seen some patients who've had, I'm going to call it tubal surgery, because people have tubal surgery for different reasons. What if you have a cyst within your fallopian tube and that tube was removed? Doesn't always have to be risk-reducing surgery, but I have seen some cases where a patient had documented normal reserve prior to the salpingectomy. They have a salpingectomy, no chemo, as Dr. Theodoulou was alluding to, and you remeasure the reserve and it's lower. And then we wonder, is it because of the surgery? And if so, what would be the mechanism of action? Are we limiting blood flow to the ovaries when we remove the tubes? I mean, we do know that there's some aspect of a shared blood supply. But I don't think it's really clear. And then we see other patients who've had no change in their ovarian reserve. So I do think we need more data to really get a better grip over how the ovarian reserve is affected. And I mean, obviously you can control for many factors like age and body mass index and, have they had chemo or not. And you can isolate just the effect of the salpingectomy, but I don't think it's clear. And I think just kind of anecdotally looking back, I've had cohorts of patients where the reserve is lowered, and I'm surmising that it was a surgery, and then other cohorts of patients where nothing has changed.
I think it would be important to have a real world study as we're seeing more and more patients go through these procedures, and we're learned enough to be able to identify those patients, start accumulating some of this data, even if it is retrospective, just to be able to try to gain some sense out of it. And again, we don't have that information, but, going back to this patient that I wanted to present, who is now 40 years old, diagnosed at 29 with an estrogen and progesterone positive, HER2 negative breast cancer, had dose dense chemotherapy with anthracyclines and taxanes, and then obviously had her surgery up front, had radiation therapy to consolidate her local control, went on to endocrine therapy with ovarian suppression and an aromatase inhibitor, and stopped it at about 7+ years, for a number of reasons. Her bones were taking a hit, her mental status was taking a hit. It was quality of life issues, and how much more benefit were we going to get for those additional 2 years or 3 years, when we started to see data coming out of Europe that maybe 7 to 8 years was enough. And her menses recovered immediately. She started menstruating, and the one issue that I did not say is that she is carrying a deleterious gene mutation. She's carrying a p53 mutation. So she's 40 years old. She very much wants to have another child. She's menstruating regularly. She's entertaining, meeting with a fertility specialist. What are the odds of her being able to have a successful pregnancy? And does she really want to have a successful pregnancy? What she really asked of this group right now is, could she harvest her eggs, have them fertilized by her husband, see how many embryos they could get? And is there a way to test for which embryo would have a p53 mutation? What are we doing today? I mean, we've gone from almost 3 decades ago, not knowing whether insurance would be taken from us, whether we would lose our jobs if we were carrying a gene mutation, what the community and ethical and professional biases may be. What does this woman do? Where does she go? What is she going to hear? Sonia, this is clearly on you.
Yeah, so I mean, it's a very good case to sort of dissect, because there's so many layers to this, right? Her diagnosis, the number of years she was on endocrine therapy, her biological age, and then obviously just thinking about probabilities in terms of how many embryos are going to be impacted by this deleterious p53 mutation. And then importantly, also thinking about the chromosomal disposition or status of the embryos. So thinking about things like Down syndrome, Turner syndrome, other aneuploidies that may not be compatible with life. So a lot of layers to this, but I think like any case, looking at that individual and first of all, asking ourselves, what is her ovarian reserve? So kind of always going back to that. What is her FSH? What is her follicle count? What is her AMH? And that is going to be the first thing to guide us as to, is she even a candidate for ovarian stimulation and harvest or not? So if her levels are in the perimenopausal, menopausal range, then obviously clearly, it would not be beneficial. In fact, I think the risk would outweigh the benefit to put her through stimulation and a surgical procedure, and obviously exposure to anesthesia. If she does have a reserve, I think until we go through the process, are we going to be able to understand in real time, is she able to create embryos, and what is the quality of those embryos? So just as an example, let's say she does have a reduced reserve for her respective age at 40, but it's acceptable. We think that we can get a reasonable number of eggs. And in general, when someone is 40, we want to be getting, greater than 5 eggs. And when you're doing embryo testing and thinking about the level of attrition, I think in an ideal world, we'd want to be greater than 10. But sometimes that's not always possible. And sometimes it's trying and giving that patient our best effort and chance so they have closure. But we would stimulate, of course, harvest eggs, carry those eggs through the fertilization process, and 5 to 6 days later, we would understand, have we been able to create good quality blast? That's the first benchmark that we need to reach. If they are good quality, meaning our structural assessment of the embryos, now this affords us the ability to genetically test the embryos for the P53 mutation, and simultaneously the DNA that we extract, we can also assess that DNA for aneuploidy. So double testing. And then of course we freeze the embryos, so they're kind of suspended in time until we get the reports back that delineate the disposition of each embryo. Does this embryo carry the P53 mutation? Is this embryo chromosomally normal? I think that what can lead to the complexity is the results itself. What do we do ethically if an embryo does not have the P53 deleterious mutation, but what if there's a chromosomal abnormality, and vice versa? I mean, I think as a purist, we want that embryo to not have any abnormality, but it does lead to an ethical conundrum, which do we value, most? The chromosomal health, the genetic health?
We've gotten so sophisticated, and what we're doing is becoming scarier and scarier on some level. I try to push my patients to have egg harvesting done before we start chemotherapy with, the data that's been gleaned over the years, that we advance the age of those follicles by 10 years, just from the exposure of chemotherapy. Regaining one's menses does not mean that you're going to regain fertility. We know now with treatments like dose-dense ACT that 20% of our patients may become amenorrheic, but 80% who are under 40 will regain their menses. Whether they're going to regain their fertility or not, we don't know. And so I think it's really such an important multidisciplinary approach, whether the patient comes to see Dr. Godoy, to talk about what her risks are regarding ovarian cancer, at what point in time should she have prophylactic surgery, whether somebody is being screened in a breast cancer clinic because of a family history, because of genetics. I think that conversations have to be had early about what is available to these patients so they're not blindsided down the line. Now we're using Lupron with our adjuvant or neoadjuvant chemotherapy drugs. Colleen knows, in order to protect the ovaries and the follicles. Is it 100%? Absolutely not. But, certainly we've gotten more pregnancies from, using ovarian suppression, putting those ovaries to sleep during cytotoxic exposure. Colleen and I see a lot of young patients. Our practice is kind of skewed to young patients, probably because of who we are, and they do come to us. And I know that, Colleen, you have been waiting for this positive trial to be published for a couple of years now. We've talked about it in our back room. We've talked about what it may mean to our patients. And when the data was presented by Ann Partridge at San Antonio, with her European colleagues, it was really what we had all hoped for. Can you tell us a little bit about what this positive trial is?
Yeah, so that's really exciting data that was presented by Ann Partridge at San Antonio Breast that Maria was lucky enough to participate in. So, the positive trial was a long-standing trial, and I believe, Maria, it started accruing, I think that the dates were, I forget the year that it started, but it's been a
So they started accruing at about 2019. There were 518 patients who
across
came
countries.
from multiple countries, multiple sites. I think there were 20 countries and over 100 sites. And most of the patients were European or from Asian countries or India. I think about 20% were from North America.
That's right.
Tell us a little bit about the design of the trial.
Yeah, so
This was, everybody, this was not a randomization, this was not half of the patients did this and half didn't. Everybody who came onto the trial for the following reason.
Right, and kudos to the patients that actually came onto the trial, because it wasn't like they were seeking the benefit of a drug, or comparing side effects of one drug versus another, or the benefit of one drug versus another. The patients really elected to go onto this trial really for benefits of future patients, I think, and it really gave our patients today the data that they needed to feel safe to have pregnancy post breast cancer diagnosis.
Yeah, the bigger issue is that, we see these patients and they're hormone receptor positive. We're going to recommend endocrine therapy because we know that the data is old now. Hundreds of thousands of patients who have been treated, as well as those patients who are under 40 who have been treated with endocrine therapy, have had better survival outcomes than those patients who have not been treated. And, we're talking about patients who are young, who are going to live a long time. They're looking at many, many years ahead of them. And would it be safe to interrupt their adjuvant endocrine therapy for them to pursue the potential of a pregnancy? And would that perhaps increase their risk for recurrence? Would their outcomes be deleterious? And that was really the design of the trial, that women would be no older than 42, that they had to have received at least 18 months of adjuvant endocrine therapy to no more than 30 months of adjuvant endocrine therapy, whether that was tamoxifen, whether that was ovarian suppression with an aromatase inhibitor. And those patients could then stop their endocrine therapy, move forward with a washout period of a minimum of 3 months. I've always said 6 months to my patients, but that's because I'm terrified. But it looks like 3 months is an appropriate washout, and then allow them to move forward and pursue pregnancy. What were we going to find out? What were we going to find out? Or were we going to see more recurrences? Were we going to see that? And these were stage 1 to stage 3 patients. These were not all early stage 1 patients with a healthy mother effect. These patients had been treated with chemotherapy. These patients were treated with advanced endocrine therapy. And what they were looking for was a futility at a 3-year median follow-up. If they had 8% of patients recur within that 3-year median follow-up, the trial would be stopped, because then it would be considered dangerous. And what they found at 41-month median follow-up, that they had 44 recurrences. So when you do the math of all the patients that came onto the trial, it was about 8%. But when you looked at the retrospective cohort of the SOFT trial, now this was a trial that when patients were diagnosed with stage 1 to stage 3 breast cancer, they looked at tamoxifen for premenopausal women versus ovarian suppression with aromatase inhibition. And we were able to see that suppressing the ovaries actually benefited these patients by way of survival. That recurrence rate was 9%. So stopping your endocrine therapy, interrupting it for no more than 2 years, trying for 2 years to have a baby or two. There were some twins born. They wound up with 74% of these patients having at least one pregnancy. Yeah. All right, that's a huge number. So 317 patients had 365 babies, and there was no excess in recurrence. Now, this is a short median follow-up.
41 months. Mm-hmm.
All right, and Colleen will tell us right now what's the concern about hormone receptor positive disease.
Yeah, long term. So they need to follow these patients 10 years out.
Yeah, we really do need to follow these patients long term out, because these are the patients that may recur later on. But when you look at tit for tat, we found that there was no deleterious effect. So now patients can get through almost half of their endocrine therapy and say, it's time for me to stop. I want to try to have a baby. I want to meet with Dr. Elguero. I want to move forward with whatever I have to move forward with by way of egg harvesting, embryos, trying to have it, reintroduced so I can carry this pregnancy. we don't say no anymore. Now, I play devil's advocate when I have to have this discussion. It's usually I ask for the partner to come in to the room, usually after hours, so we can have a long discussion. And I give up all these scenarios. Certainly I'll be talking about the positive trial and how exciting it is. But then I ask on that individual basis, well, what happens if you are pregnant and you find out you have a recurrence? What happens if you have this child and you have a recurrence? Will your partner be responsible? How do they feel? You have to take every single piece into consideration. So I throw out the worst case scenario to my patients, and they'll either say to me, oh, whoa, we had to think about this. Or they'll say to me, Dr. T, we love you, but we can't wait to become pregnant. And I'm there with them. I'm there with them. And, I can honestly sleep better at night now, given the positive trial. But I suspect that we're going to be seeing more and more patients coming to our fertility clinics. I think as the data evolves and we speak to egg harvesting early on, I think the issue that Heidi brought up is so all important, because we don't know if somebody has a hysterectomy or has their tubes removed, if that's going to decrease their ovarian follicle reserve. We don't know. There's so much that we don't know. So I think being proactive early, is all important. Obviously, the trial has to be followed for many, many years, but it was a standing ovation trial, a very enthusiastic trial. I wanted to talk a little bit about, and it's kind of going off, and then we have some questions that I'm going to address. I've already asked some of them in this presentation. What about HPV and cervical cancer and our adult women who have gone through a breast cancer diagnosis, and maybe this was a wake-up call for them? They've gotten out of a bad relationship, or they're getting into a new relationship. They're now 40 years old, 44 years old. Heidi, what do we tell these women? Colleen, what do we tell these women about HPV and vaccination? We're talking about our adolescents, our kids, let's get them vaccinated, at an early age. What do we tell these women who have been in a single relationship or have not been in any relationship? What do we tell these women?
You want to start, Colleen?
Well, yes, I'll start. Yes. First of all, more power to the patient, right? So kudos to them that they've, engaged in a healthy sex life. They're happy, healthy, and really want to have that. First of all, I think it's important that they have that conversation with us, because, a lot of times we don't often ask patients, about their sexuality, their sex life. Do they have concerns? So I think bringing that up with the patient, especially our patients that are older, that are now in a new relationship, then we can talk to Heidi and say, listen, we have this patient, she's now 45, 50 years old. She's now having a new relationship, or maybe multiple new relationships. How do we keep her safe? How do we protect her against sexually transmitted disease, cervical dysplasia, HPV? So again, Heidi, I'll defer to you about the Gardasil vaccination for.
Well, so let's first start with January is Cervical Cancer Awareness Month. Traditionally, when you think of cervical cancer, we are declining our rates of cervical cancer because of our wonderful screening, the Papa Nicolau. It's a pap smear. It's probably what you're generically known as. And we also do HPV testing. So a lot of women in their 20s test positive for HPV. And so I use this analogy with my patients. When you're in your late teens and your 20s, you try on a lot of people, right? You're looking for that magic person, right? So you get exposed. And during your 20s and your early 30s, you're likely to clear this virus. Okay, it's like a cold. Okay, but this kind of cold can then hide in some of your nerve roots, and it can go dormant and then see a reactivation. So some people can have the HPV, clear it, and then maybe 10 years later, they'll see a reactivation of it and they'll be positive. And then they're concerned that they have a cheating spouse or somebody wasn't faithful to them. No, it doesn't happen like that. Can always happen. However, there's always concern that this is a reactivation of the virus. So majority of people in their 20 and their early 30s will clear this virus. So I don't get super jazzed up about abnormal pap smears or HPV positive in people who are in their 20s. I make sure they're vaccinated with the Gardasil vaccine. And people say, well, I've already been exposed. There's some data to suggest that it might offer you some cross coverage with other types of HPV types, because there are hundreds of types of HPV. We talk about the big ones, the 16, the 18, the 31, the 32 or 33, but there are hundreds of types of HPV. Some that cause cancer, some that cause warts. And so when your child is, pre-sexually active, you really should vaccinate them, boys and girls, okay? It's not just a girl's problem, it's a boy's problem as well. So be cognizant of that. So I think to talk about what a screening test is, it's a test to detect if there are any abnormal cells, okay? That does not test for ovary cancer, it does not test for endometrial cancer. It is a screening test for abnormal cells on your cervix, okay? So we get that result back, and we also can check you for HPV. If you're HPV positive for low risk HPV, okay, we're just gonna recheck in a year. If you're high risk HPV and you have abnormal cells, we might take a microscope and take a closer look. But this is a screenable disease. When you go to your OBGYN or you go to your PCP and you're getting your internal and they say, oh, you don't need a pap smear for 5 years. I kind of cringe, because if they're not really asking you your sexual history, then that's not really accurate. Then you want to say, I have multiple partners. Then you most certainly should get a pap smear every year. I have a history of HPV. Then you should have an HPV and a pap smear every year for the next 20 years, not every 3 years, not every 5 years. You need to have this test. And sometimes the PCPs, I notice, are saying, oh, you're not due for an exam, like a pap smear. So they don't even do the pelvic exam. Your lips, your vagina, your cervix, your vulva, your whole area needs to be evaluated yearly. You can't see down there sometimes, so you got to get a mirror out. You got somebody else to take a look at it. So I highly recommend it. It's really important. The last thing I would like to add is that the HPV vaccine has been approved by your insurance up to age 45. So if you have not been vaccinated, come on in. We are doing it at NYOH. We can do it for you. Go to your primary care doctor, go see your OBGYN, get your vaccine. And don't be fooled about this every 5-year pap smear if you're kind of fit into one of those other categories. So that's my soapbox, Maria.
Thank you, Heidi. And I think your soapbox should be higher. The incidence of anal cancer is increasing.
Yes.
We lose sight of the fact that that is a target area for HPV, head and neck cancer. It's really unfortunate. I mean, we have a perfect celebrity who came out there, Michael Douglas, and if he isn't a poster boy for, getting vaccinated and being proactive, at a younger age, then, hey, then we're fooling ourselves. And I think I'm going to throw this at you, Colleen. I think you're surprised as much as I'm surprised that we do take a sexual history.
Yeah, we really do. I feel like
how do patients react to that?
Yeah, I think we always try to bridge that topic with our patients, because sometimes I'll see other patients and, like for one of our male practice partners, and they're like, I'd rather talk to you about this because I can't imagine talking to them. But I think if we don't speak to the patients, we're doing them a huge disservice. We're doing ourselves a disservice, because like Heidi had said, the patients need an exam yearly. They're, if they're sexually in relationships with multiple partners, someone needs to take a look, because, we're missing melanomas of the vagina, melanomas of the vulva. So I think taking a sexual history is so important for patients, and just having the conversation, talking to them about vaginal dryness, talking to them about how they're feeling when they're having intercourse. Are they comfortable? Are they having body issue images? issues. It's just a whole complicated issue for us.
I am so thankful because I think you guys do a fabulous job of then directing them to where they need to go. So I am always duly impressed by the sexual history that you take. And it kind of opens it up that, hey, I didn't realize that my doctor should be talking to me about this. My provider, how did they, and I go, well, this is how you communicate. You know what I mean? And there are very easy standard questionnaires we can answer, but sometimes you're doing their exam and you're like, are you using your vagina? As easy as that.
Right.
You know what I mean?
Are you having pain?
Do you want to use your
And we
vagina?
have to be very careful about biasing ourselves by age. I have women who are in their late 70s and early 80s who are devastated because they can't have successful intercourse with their husbands, or whatever, playfulness and gratification they want to receive, because they don't know how to keep their sexual health healthy. And you can't do that without sharing information that's evolving all the time, seeing experts like Dr. Godoy, feeling open about having the discussion. There are sex therapists out there, even in our area, up in the Albany area, that it's not going to a triple X rated movie. It's having a conversation about how to keep a very important part of our body healthy. And, I have to be very careful about what I'm about to say, but it's a very Western bias. If you go to European countries, if you go to South American countries, our elders are sexually active, or they're concerned about their sexual health and how they feel. It's so all important. And even actually discussing it with male patients.
I agree.
I had a male patient that came into me that was in his early 80s, diagnosed with a breast cancer. It was locally advanced because, unfortunately, men aren't geared, they're not educated to try to pick up a breast mass. They think it's a boil, or they think it's some, just traumatic event. And he was this older, wonderful gentleman, was diagnosed with a breast cancer. And the same thing as a woman, I need to find out if they're pre or postmenopausal. So how do you approach this with a gentleman in his early 80s who's probably never had a discussion? I found that he had never had a discussion. And I said to him, in the privacy of the clinic room, I said, are you sexually active? And he was alarmed and said, my wife passed away, I forget what it was, 10 years ago or 15 years ago. So I knew I had to I said to him, do you ever wake up with an erection? And he said, every morning. I had to suppress his testosterone to make his breast cancer reduce so I could treat him appropriately. And it always brings a smile to me, because I took care of a lot of prostate cancer when I was at Sloan Kettering, and certainly thousands of patients with breast cancer, men and women, that we have to have this conversation. We have to talk about it. Sometimes we'll miss our therapeutic goal if we don't talk about it. But it's certainly important. And what Colleen said earlier, being able to identify those patients who may be, whatever their personal lifestyle is, with multiple partners, or for whatever the circumstances, that they've had more than several partners, that they be taken care of, that they be kept healthy. And Heidi, I'm so happy that we could pick up the phone and say,
I love it.
C, A, B, C, D, and you're always, yes, this Friday, this Thursday.
Well, I try to be kind. Everybody's vagina needs a little love. So absolutely.
I just wanted to, sorry.
What do you guys want to bring up today? A lot of the questions that came in have really been covered by what we're talking about. Sonia, what would you like to bring up?
I just wanted to bring up a couple of quick comments, just going back to the positive trial that Colleen was talking about. When you think back to, how things were, like just rewind the clock 15, 20 years ago, women were younger when they were completing, their childbearing. And now you look at current times, more women,
Right.
educating themselves, going into the workforce. There's a shift in our society. It's more acceptable to be divorced, to be with a new partner, to remarry, etc. And as such, breast cancer is being diagnosed before the completion of childbearing. This is a marked change, a generational change. And so when you think about the stress, just the burden that puts on these breast cancer patients, this trial is actually pretty pivotal to have some reassurance. I know we don't have the full results and they have to be followed long term, but to interrupt endocrine therapy after roughly 18 months and to say you have a dedicated period of time to conceive, to deliver, to breastfeed, and then resume your therapy, I think it's huge because there's always this fear or prejudice, if that's the right word, especially against HR positive breast cancer. We fear, we don't want any harm to be inflicted upon the patient by interrupting therapy. So I think, really reassuring data so far to know that we can interrupt it and allow women to carry at younger ages. And that is important in terms of even just reducing risk during the pregnancy itself, to go through pregnancy, for example, at 36 as opposed to 42. And to be younger parents is very meaningful, And I think finally, just thinking about harvest of eggs and embryos, we know that this can be done on endocrine therapy. So we can harvest embryos while a patient is taking an aromatase inhibitor or tamoxifen. It doesn't have to be done during the interruption. And so that's actually important because then that interruption can be used to carry the pregnancy, to transfer the embryos or to create embryos from frozen eggs. And that would be very efficient.
I think you're going to be seeing so many more patients coming your way, and with a smile on their face, because we in the medical part of it will be pushing them that way, and it's true. I mean, women now are thinking about having their first baby in their late 30s, their early 40s, mid 40s. And there's one question that came up that I'm going to read just out of respect, out of everything that's, so I am a 45-year-old breast cancer survivor. I harvested and fertilized when I was 37. I am also BRCA2 positive. I saw a specialist in Boston who told me I could move ahead with carrying my own embryo if viable, which is very much what you've been saying, Sonia. My ONCA score was also very high. I had 4 months of dose-dense chemo. I'm looking at celebrating 9 years as a cancer survivor. So bravo, whoever this is. I have also tried for years to find someone to carry my embryo with no luck. And that becomes an issue because it can be very expensive. It may not be available, and having a surrogate is not just, picking up the phone and calling someone. And then she says, I've always wanted to be a mom. I'm up for adoption. I'm also a foster parent, but would like to have a child that looks like me, which is frozen in Latham. My dad is the one who carries the gene. He's never been formally tested. My mom was tested and was negative. Not one of my dad's sisters is positive for BRCA, but 2 have had cancer, one with ovarian cancer and breast cancer, and one with just breast cancer. So I think we have to and she writes any advice in capital letters. So I think we just have to break this up a little bit. She's a 9-year breast cancer survivor. She's got apparently an embryo that's frozen and waiting for her. She's now 45 years old. Is that too old to have a baby? I don't think so. Not today. What would you say to her? What would you say to her, Sonia?
I think, first of all, it seems that, she has some concerns over the embryo that's frozen and thinking about the genetic disposition. I think we need to be very sensitive and thoughtful to how is that approached. If this is the only embryo she has and it was created when she was younger, it should have a good potential to implant and to be chromosomally normal. The concern with trying to understand its genetic disposition, let's say, we understand that we're able to make a probe to, I believe she said her father may have had BRCA. We're able to build a probe and we're able to probe that embryo. We have to understand that there's some risk to harming the embryo. It has to be thawed, it has to be biopsied, it has to be refrozen, and then if it's unaffected by BRCA, it has to be thawed and then utilized. So in that pursuit to understand if it's genetically affected, it could compromise the embryo. So it's a sensitive and delicate situation, but part of it is, do we value the fact that it's a younger embryo that may result in a viable pregnancy, or do we value understanding its genetic disposition? And that's challenging. I think so much depends on the values of that patient. And just what her goals are for fertility. People that are open to fostering and adopting, maybe it's more important to have a child that's healthy, that's unaffected by the mutation. Maybe that's more valued over getting pregnant and carrying. So I think a lot of thought needs to be put into that embryo and information obtained on its quality. Can it withstand biopsy? What was the freezing technique? All those things need to be thoughtfully discussed, but I agree. I don't think she's too old to carry. We always say the uterus doesn't age, but more so looking at the maternal health, outside of her being a 9-year survivor, but looking at her general health and could there be any risk to carry based on her, her medical history and health.
I knew that time was going to run out and we were going to have a lot more to say. And I want to thank all of you for being here. Colleen, after a hard work day, we've seen so many patients today. You still look perky. Sonia, I can't thank you enough for all of this information. Heidi, I've already gotten somebody saying that thank you for that information that you gave. I don't know whether they're going to go get Gardasil or whether they're going to have their tubes out. But, I'm getting a lot of, thumbs up here. We're going to continue these programs and we're going to try to have them once a month. And certainly we're going to invite all of you back as panelists. I think we have to be careful about being sensitive to the audience that's out there, trying to garner these questions maybe before the programs start. I'm really excited. Next month, we're going to talk about precision medicine, and people are going to say, what's precision medicine? Well, we're in a world today where we are individualizing therapy, understanding genetic mutations of individual breast cancers. We're going to bring it to the forefront by an expert from California who is going to be able to discuss all of this with us in a language that we're all going to understand, including myself. So I'm really excited about having Dr. Holloway on in February. We're going to have Dr. Iyengar come back with his nutritional advances and some of the issues regarding obesity and breast cancer. We're going to have programs that are going to cover new modalities in breast cancer screening. We're going to bring updates in various stages of breast cancer, including stage 4. None of these programs could happen without the incredible generosity of Stacy Fisher-Rosenthal, who has been supporting these programs year after year after year. We now have a new donor, Dr. Saida Baxt, and our foundation, who is allowing us at NYOH to help disseminate this information to so many people. I'm hoping that soon we'll have primary care physicians, all subspecialties, people from all walks, and this is just going to grow. And I have to make sure that I show this particular slide before we finish. Can you see the slide that I have up here? Or am I seeing it by myself? Can everybody see the Akira slide? Well, let me do this. Now, can you see it?
Yes.
Okay, so I just want to close by saying Akira is our new medical imaging and wellness center. It is incredible. It is state of the art. It is gorgeous. It is friendly. And when we're going in for our screening and diagnostic mammograms and breast ultrasounds and pelvic ultrasounds, sometimes we're not going in the best of moods. They're going to make you feel good. Never mind that the gowns are warmed up before you wear them. So I hear from my patients, that's the best part. I loved it. DEXA scans, you'll get your results the same day. This is going to just grow and grow, and soon we're going to have ancillary services, educational programs there. So be aware of it. Thank you, guys. I'm going to close the program.